Okay. So we will start by looking at Dr. Lobo's question. I believe there were 15 questions. I'm going to try and get through as many of them as I can in this hour. So for his first question, what is Cole's fracture? How do you get this? And what are the clinical symptoms? So for Cole's fracture, I do have a review PowerPoint just on the hand. I will send that to your class rep. Let me make sure. Write that down. I will send it to your class rep so you guys will have this to review. But a Cole's or Colles fracture, depending on how you want to pronounce it, is the most common fracture of the forearm. And you can see how it's at the distal radius here. It is a complete transverse fracture of the distal 2 centimeters of the radius, commonly known as the dinner fork deformity. So when you look at the patient's hand, it's sort of like the wrist looks like a dinner fork after the fracture. This type of injury is caused when your patient falls on their outstretched hand. So falling on an outstretched hand is a Fuchs injury. And often when this fracture occurs, the ulnar styloid process is avulsed, so it's ripped off as well. So you can see that in this picture. So this is a Colles fracture. Okay. So
did you say falling on an outstretched hand?
yep, Fuchs, falling on an outstretched hand. It can cause many different types of fractures. This is one of them.
Okay. Thank you.
Sure. Okay. So question number 2, what is tennis elbow? Where will be the focal point of pain? And then also the corollary, what is golfer's elbow? What will be the focal point of pain? All right, I think that's in here. This one? Okay. I thought it would be in this one. So tennis elbow and golfer's elbow have to do with your flexor and your extensor muscles being irritated from overuse. I know I have it in one of these PowerPoints, but I can't remember which PowerPoint I have it in. If it's not in this one, I don't know which one it's in. But yeah, so actually, hold on. I think it might be in his PowerPoint. Maybe. But yeah, so that's what's happening is and the way that I actually remembered it is I would think about a golf swing versus coming over with a tennis racket. Like that's how I would remember which is which. But let me find you where he talks about. Oh, and here's his thing on Cole's fracture. And this one either, really?
I think it's in his cubital fossa PowerPoint.
Okay. Let's try that. There we go. So when it comes to tennis elbow, this is going to be your extensor muscles versus golfer's elbow is going to be your flexor muscles. So when I think of this question is which one is which, for golf, you have to, like, I don't know if folks have golfed before, but you have to swing your arms such that when your arm comes up, you're flexing at the elbow when you bring like the golf club to the right, like to your, if you're right-handed, towards your left and swinging it over. So that's how I could remember that it was flexion. Versus for the tennis elbow, it's extension because I would think of doing a backhand. So doing a backhand is going to cause extension at the elbow. Both of them have to do with the fact that it's inflammation and irritation causing the pain, and it's always from overuse. So people who are playing too much tennis or playing too much golf and not taking the time to rest their elbow, like you would do rest, ice, hot compresses sometimes, and elevate, I believe. And then you would take like an anti-inflammatory, so like an NSAID or ibuprofen to help. But for the people who don't actually rest their elbow, you can get tennis elbow and golfer's elbow. So you just have to know golfers is with flexor and tennis is with extensor. And then from that, you want to know the Maxwell point of pain, they both have common tendons. So there's a common extensor tendon and a common flexor tendon, which let's see if we can find a good picture of that for you. So you can see, and why are you? So your extensor is going into your common extensor tendon. That's the one that's going to get irritated with tennis elbow versus for your flexors, it's going to be the common flexor tendon, which you can see here. So common flexor tendon, golfer's elbow, common extensor tendon is tennis elbow, and that's going to be the point of pain, where like the irritation and inflammation is going to be the most, like it's going to be the worst for the patient. Okay. So next questions. What muscles and nerves are responsible for flexion of the proximal interphalangeal PIP joints? Are they the same for all 4 fingers? What muscles and nerves are responsible for flexion of the DIPs? Are they the same for all 4 fingers? Okay, fun. So let's go back and talk about your anterior forearm compartment. So when it comes to flexion at the DIPs versus the PIPs, you're going to need to know different muscles and how they're innervated, and it gets to be a little bit funny, or it gets to be interesting. So you have your flexor digitorum superficialis muscle. Your flexor digitorum superficialis muscle, the tendons actually insert at the distals. So you can see here how they actually came through, and like your, that's the profundus that goes all the way to the end. It's the flexor digitorum superficialis that splits for the profundus. So 2 muscles are important here: flexor digitorum superficialis and flexor digitorum profundus. Flexor digitorum profundus goes all the way out to the tips of the fingers, versus flexor digitorum superficialis splits in half and inserts here at your middle section of your phalanges. So when we talk about the distal versus the proximal joint, so you can see here, this is the distal phalange, so this is the distal joint, versus this is like the medial, and this is the proximal. So because you have this tendon inserting at the very tips versus this tendon is inserting at the medial portion, profundus actually does the flexion just at the tips of the fingers, versus superficialis does the flexion for, if you watch the Dr. Preddy video, he talks about like doing like your puppet fingers, but it's flexing here, and they are innervated differently. So flexor digitorum superficialis is just median nerve. However, flexor digitorum profundus, though, it has split innervation. So flexor digitorum profundus has partial innervation by ulnar nerve and partial innervation by median nerve. We call it the ulnar half and the median half. So when you're learning about your hand, you learn that the ring and the pinky finger are mostly ulnar nerve versus the index and the middle finger are mostly median nerve. So that's how it's split with flexor digitorum profundus. It has these two tendons that are going out to the ring finger and the pinky finger. Their muscle belly are innervated by ulnar versus the two that are going out to the index and the middle finger that's innervated by median nerve. And that's one of the ways that they can trip you up when asking about flexion at your distal joints, because it is two different nerves. So just to like reiterate what I just said, for your answer for 5, what muscles and nerves are responsible for flexion of the distal interphalangeal joint? Are they the same for all 4 fingers? This is flexor digitorum profundus, and it's the same muscle, but it's different nerves. The median side, which is your index and your middle finger, is innervated by median versus the ulnar side, which is your ring finger and your pinky finger, is innervated by ulnar. Versus for the proximal, this is flexor superficialis, flexor digitorum superficialis, and that's just median nerve. So far, so good? Okay. Cool. So, number 6, how is flexion of your distal interphalangeal joints of the ring and little finger different from the index and middle fingers? Well, we just talked about that with superficialis versus profundus. Name all of the muscles supplied by the median nerve. Okay, so I made a handy dandy slide set for this. That's radial, that's ulnar. There's median. Okay, so muscles innervated by your median nerve. I pulled this straight out of Netter. I liked these particular plates because it showed you cutaneous innervation along with the muscles and the path that the nerve takes. So this picture is it literally only shows muscles innervated by median nerve. So your pronator, so muscles of the anterior compartment of the forearm and muscles of your thenar eminence and your hand. Those are innervated by median nerve. So you can see how we have pronator teres, we have flexor carpi radialis, palmaris longus, pronator teres, flexor digitorum superficialis. Although, hold on. But yes, that's the second pass of pronator teres and then palmaris longus. Yes, so that's the first PF pass fail. Your flexor digitorum profundus, specifically the median side, the median nerve side. Your flexor pollicus longus, your pronator quadratus, and then you can see how your median nerve goes into your hand, is now innervating the 3 muscles of your thenar eminence, which is your abductor pollicus brevis, your opponent's pollicus, and your flexor pollicus brevis. Can you explain the first 2 lumbricals, please? Okay. All right. So let's talk about the hand. I'm disappointed for y'all that you're getting hand questions before anybody's actually talked to you about the hand. But let's talk about the hand. We'll skip over carpal tunnel for now. Okay, that's cutaneous innervation. Okay. So when it comes to innervation in the hand, I like to use the mnemonic 1/2 loaf. I thought I wrote it down here somewhere, but that's how you remember what is innervated by what. So where are you? There we go. The muscles in the hand are mostly innervated by ulnar nerve, except for 1/2 loaf. So to translate this mnemonic, you have lumbrical muscles on your index, middle, ring, and pinky finger. So 4 lumbricals, or four sets of lumbricals. The median nerve innervates the first and second lumbricals. So here and here. The median nerve also innervates your Vayner eminence. So Vayner eminence is abbreviated OAF for opponens pollicis, adductor pollicis, and flexor pollicis brevis. So these are like the muscles that are innervated by median nerve in the hand. Everything else in the hand, the muscles at least, are innervated by ulnar nerve. So when thinking about innervation of muscles in the hand, if it's not the first or second lumbrical, or the opponens pollicis, abductor pollicis, or flexor pollicis brevis, then you know it's innervated by ulnar nerve, because these are the only muscles in the hand that are innervated by median nerve.
Kristen, could you point out what a lumbrical is again?
Sure, here, let me show you. I'll go like the actual lumbrical like picture. So these are your lumbrical muscles. So you can see how like there's 4 of them, 1, 2, and then 3, and then 4. And how your first 2 lumbricals, there's only 1 muscle belly, versus your third and your fourth, there are 2 muscle bellies. So they can also be called your unipinnate and your bipinnate lumbricals. And you see how this one is inserting on your index finger, this one is inserting on your middle finger, versus this one is inserting on your ring, and this one is inserting on your pinky finger. So these are your lumbrical muscles. 1 and 2 are innervated by median nerve, versus 3 and 4 are innervated by ulnar nerve. So what's interesting about the hand is that there's a lot of little muscles that you'll have to learn. So like there's the lumbrical muscles, there's your pads and your dabs. It's a lot of little stuff. Like, so when I was saying oaf before, that was for abductor pollicis brevis, but there's also an adductor pollicis, which has both a transverse and oblique head. There's just a lot of things, like a lot of little things in the hand, unfortunately, that you need to know. And he's asking you questions about it before you guys have had a lecture, which is unfortunate. But yes, so here are your lumbricals, 1 and 2 versus 3 and 4. And you can see how they've started on the tendons of your flexor digitorum profundus, but they've inserted on the sides here of your bones. Does that make sense?
Yeah, that makes sense. Thank you.
Sure. Okay. And now I'm trying to remember the question that he initially asked, so I'll just go back. Okay, yeah, all the muscles supplied by the median nerve. So going back to that picture that I found in Netter, that's showing you all the muscles supplied by median nerve. There's also, so I'm going to send this PowerPoint to your class rep too, but there's one for each of like the major nerves. So here's musculocutaneous, here's median, here's ulnar, and then it's 2 slides for radial because it's so many. And in these slides, it's also showing you like the cutaneous innervation for each to help you remember as you're studying. Okay. But yeah, median nerve has a lot of muscles that it innervates. When I was learning it, it was anterior compartment of the forearm is mostly median except for 1.5 muscles. So the half is this ulnar half of Flexor Digitorum Profundus. And the 1 is the muscle that actually has ulnar in the name, which I think is Flexor Carpi Ulnaris. Which, there it is, Flexor Carpi Ulnaris. This one's innervated by ulnar nerve. But everything else in the anterior forearm is median nerve. Okay. So median nerve is all of the muscles in the anterior forearm except for your 1.5, which is Flexor Carpi Ulnaris and the ulnar half of Flexor Digitorum Profundus. And then your Vayner Eminence in your hand is innervated by median nerve. So that's your 1/2 loaf. So your first and second lumbricals, and then the OAF of the Vayner Eminence, which is Opponens Pollicis, Abductor Pollicis brevis, and Flexor Pollicis brevis. Okay. Go on to his next question. What sensory area is designated for the median nerve? Median doesn't innervate anything in the arm. So yeah, the proximal arm, correct. That's Musculocutaneous that's doing that. Okay. Sensory area designated for median. So that was also on that slide. Oh no, that's Musculocutaneous. There we go.
Hello, let me ask this quick question for you. I know that the median nerve doesn't is not responsible for any sensation in the forearm, but what is? If you can tell me that, then I can remember like that's what does it instead.
Sure. So going back, there was another really good point here. So you can see here how you have your medial antebrachial cutaneous nerve as well as your lateral antebrachial cutaneous nerve. This is the anterior portion of your forearm versus the posterior portion of your forearm. It has both of those plus part of radial nerve here in like the reddish purple as opposed to the more bluish purple. So this reddish purple here on the posterior forearm is radial. The green is lateral antebrachial cutaneous, which is the terminal part of your musculocutaneous. And then medial antebrachial cutaneous came directly off of your brachial plexus. So this is cutaneous sensation innervation of your forearm.
When you were breaking down the brachial plexus, is that the bottom part? And I think I was confused about that, but now you've answered that question. This time our meeting this time, yeah. Is that the median cutaneous nerves that are innervating the forearm?
Correct. So it's
Okay.
so there's your medial antebrachial cutaneous.
Yeah, those. Okay, that makes sense.
Versus medial brachial is in the proximal arm.
Okay, yeah, it's the above. It's the where your brachii and all those are the top part of the arm.
Correct.
Yes. Okay. Thank you. Thank you.
Sure. All right, so getting back to median nerve, here we go. So this is a cutaneous innervation of median nerve. So you see how it lines up with or it correlates with muscles that is innervating in the hand. So how your Vayner eminence over here, it's like, oh, hey, Vayner eminence. And then for cutaneous innervation, it's this part of the thumb, but realize that it's not the whole thumb because there is part of the thumb down here, like the more proximal part that's not innervated by median. But everything that's in blue here is median cutaneous innervation. So just remember the splitting of the ring finger, and then it goes to the fingertips, but it doesn't go past that first knuckle. So that is like this blue is the cutaneous innervation of median. Okay. Next question. Name the muscles supplied by the ulnar nerve. Okay. So we kind of already went over this, but we'll do it again. So remember your 1.5 muscles that are innervated by ulnar nerve in the anterior forearm are the ulnar half of your flexor digitorum profundus, as well as your flexor carpi ulnaris. And then the rest of the muscles innervated by ulnar are in the hand. So if it's not the 1/2 loaf in the hand, then it's innervated by ulnar nerve. And there's quite a few muscles. So let's talk about those. Okay. Cutaneous. Okay. So I've already mentioned your thenar eminence, but you actually have a thenar and a hypothenar eminence. They both have similar muscles, but they're on opposite sides of your hand. So your thenar eminence is for your thumb. Your hypothenar eminence is for your little finger, your pinky finger. So when you hear thenar, think like thumb. You'll also see like pollicis in the names of the muscles. So flexor pollicis brevis, opponens pollicis, abductor pollicis brevis. Versus for your hypothenar, for your little finger, you'll see digiti minimi. So it's abductor digiti minimi, flexor, flexor digi minimi brevis, or flexor brevis digi minimi, I forget the order of it. And then opponens digiti minimi. But it's still OAF. It's still opponens, abductor, flexor brevis. It's just for your little finger. So thenar eminence, median nerve, hypothenar eminence, ulnar nerve. Okay, and we're going to skip over the bursa for now. Your adductor pollicis is this muscle here. It has 2 bellies. It has a transverse head as well as an oblique head. Both of them are innervated by deep branch of ulnar nerve. Just remember ulnar nerve for now. And then I talk about the symmetry of the hand to help you understand abduction versus adduction of the fingers. I'll try and do this quickly. If you look at your hand and you open and close your fingers while looking at your middle finger, you'll notice that your middle finger doesn't really move. Well, that's because the middle finger is actually the middle of your hand. So going away from the middle finger is abduction, and going towards the middle finger is adduction. But that also means that if you ever move your middle finger, you're automatically abducting. If you just rest it, it is adducted. So that comes into play when we're talking about our palmar interossei and our dorsal interossei. The palmar interossei, we nickname it pads because they do adduction, versus the dorsal interossei, we nickname them dabs because they do abduction. So since not moving the middle finger is adducted, there's no actual pad for your middle finger. It's at rest, it is adducted. Versus for your dabs, your middle finger has 2 because moving your middle finger anywhere from its rest point is abduction. So these are your pads and your dabs, and they're innervated by ulnar nerve. So once again, bipinnate versus unipinnate. So your pads are unipinnate, your dabs are bipinnate. So this just means 1 muscle belly versus 2 muscle bellies. We already talked about your lumbricals. Recall that 1 and 2 are innervated by median, but 3 and 4 are innervated by ulnar. Okay. So ulnar nerve, most of the hand except for 1/2 loaf. And it also innervates 1.5 muscles in your anterior forearm compartment. And then sensory innervation or sensory designation of your ulnar nerve. So that was in that picture. And I'll show it here. Let me show it on the nutter plate since I showed median nerve on the nutter plate. So ulnar cutaneous innervation is one half of your ring finger and your pinky finger. So this is the ulnar half of your hand when it comes to cutaneous innervation. So you'll note that it's split in the back and it can be kind of confusing. And that's because this area over here is innervated by radial. So you have radial, you have ulnar, and then you have median nerve up here. One tip that helped me when I was trying to remember cutaneous innervation of the hand is that the fingertips are never radial. Fingertip innervation is never radial nerve. Radial nerve does have cutaneous innervation on this more proximal part of your thumb, but the fingertips are never radial. It's either median or ulnar nerve. And then this is the distribution for your ulnar nerve. Okay. Next question. Name the muscle supplied by musculocutaneous nerve and the sensory area designated for musculocutaneous nerve. All right, so going back to PowerPoint that I made, I think musculocutaneous is kind of a cool nerve because it specifically pierces through a muscle in its path. So here's your musculocutaneous nerve. You can see it coming off of your brachial plexus. It actually pierces through one of the muscles and innervates. So it innervates 3 muscles. You have your biceps brachii. Here's your corpobrachialis, which is the muscle that it actually goes through. And then here's your brachialis muscle. So those are the 3 muscles that musculocutaneous innervates. And then recall that the terminal branch is the lateral antebrachial cutaneous nerve. Well, this is the distribution of cutaneous innervation for that nerve. So lateral antebrachial cutaneous, sensory innervation from musculocutaneous nerve. Okay. Next question. A person has flattened Vayner imminence. What nerve is damaged? What muscles are paralyzed? Where will there be sensory loss? Okay, so this goes back to what we were talking about with the hand. So remember that our thenar eminence are these 3 muscles. So your oaf, your opponent's pollicis, your adductor pollicis brevis, and your flexor pollicis brevis. And they're all innervated by median nerve, specifically the recurrent branch of median nerve. So if you have a flattened thenar eminence, that means that there's been damage to this branch of median nerve. And then what was the other part of the question? Flattened thenar eminence, what nerve is damaged, what muscles are paralyzed, and where will be sensory loss. So for sensory loss, though, that is where I am not sure, because recurrent branch is going to the muscles, but I don't know if they specifically have to do with cutaneous innervation. That I do not know. It could be that it would be the area over top of the muscles, but I can't say for certain. I just know that if you have a flattened thenar eminence, that means that you have damaged this nerve here, and these are the muscles that are paralyzed. I could guess that, but it's just a guess. You'd have to look that up to like be sure if that's correct. Okay. A person has flattened hypothenar eminence. What nerve is damaged? What muscles are paralyzed? Where will there be sensory loss? Okay, so going back to what we were talking about before, and go to, here we go. Here's our hypothenar eminence, which is innervated by our ulnar nerve. So it's our abductor digiti minimi, our flexor brevis digiti minimi, and our opponent's digiti minimi. So you've damaged ulnar nerve. These are the muscles. And I think it would be cutaneous innervation above these, but you would have to double check because I am not certain on that. Okay. And then finally, a person cannot pronate his hand. Where will be the sensory loss? Okay, so for pronation of your hand, okay, so supination versus pronation. Supination, you're holding a bowl of soup up. Pronation, you have dumped it onto the ground. And you get supination and pronation from two muscles that work in concert with each other. Like they're pretty much working opposite of each other. I think about a ribbon that is going over like a bowling pin or some sort of like tube, how one's going to roll it one way and the other one's going to roll it the other way. So you see how here's your pronator teres versus here's your supinator. And when you have your pronator teres performing its action, you see pronation by pulling this radial bone to cross over your ulnar bone, versus supination is pulling your radius back over and flattening them out. So if you can't pronate, that means that you've lost pronator teres, and pronator teres is innervated by median nerve. So if you've lost pronation all the way up here, that means that everything downstream is most likely going to be damaged. So if you can't pronate, and I think that's what I was asking, if you can't pronate your hand and it's innervated by median nerve, that means that median nerve is damaged all the way up there. So you're going to lose that cutaneous innervation in the hand that you get for median nerve. So it's the yellow here. So it's just remembering what happens when you have nerve damage. Anything downstream of the damage is lost. Anything upstream of the damage is fine. So if you can't pronate, that means you've lost pronator teres, which is innervated by median nerve. So anything downstream of that, you would then think, okay, that's not going to work. So you would have lost cutaneous innervation of the hand in this shaded yellow distribution. Okay. Oh, yeah. Well, so lumbricals too, yeah. Because remember, it's anything downstream. Okay. And I think we got to all of the questions. Yeah, we got through all 15 questions. And we still have a bit of time left. So what other questions do folks have? Do you want me to go over something again? Do you want me to explain something more? What would you like to do with the rest of our time?
I have a question really quick about Cole's fracture of the wrist.
Sure.
Just so I'm understanding this properly, you can tell me if I'm wrong, obviously. Is the hand look like it's called the fork, the dinner silver fork deformity, because in the relaxed position, your hand now curves? Or is it when it's trying to move?
Oh no, it's when it's relaxed.
Okay.
Here, I'll show you that picture again. But yeah, it's when it's relaxed. It's kind of gnarly. But you can see how here, just at rest, because you've broken like your distal radius, this is how the hand looks, just sitting there. And you can see how you have that curve and then the dip.
Oh,
Yeah.
that makes sense.
And they even I put a little dinner fork here so you can see it just a little bit better. But like, yeah, so that's the tongs and then it dips down.
Perfect. Thank you.
Sure, no problem.
May I piggyback off of Chica and ask you about the Smiths or the reverse version of this? So instead of pointing down, would they point up instead?
I think because for Coles versus Smith, I think it's just which way does the which way does the fracture displace? I think that's how it goes. Because for Coles, you can see how so this portion is going more posteriorly versus this portion is going more anteriorly, and you can really see it in this picture. I think for the Smith, it's reversed, but let me see. Let me see if I can find it. Nope. Okay. Has he talked to y'all about this yet?
It was in the latest PowerPoint. He mentioned Smiths, and then I was wondering, since Coles was making that fork-like shape, I was wondering, would Smiths be the opposite and it kind of like goes upwards? I was just curious.
But I wanna find a picture to like make sure I'm right on that. Do you remember what the name of that PowerPoint is?
Give me 2 seconds.
Sure.
It should be the anterior forearm one. Yes.
There we go. Yep, reverse Coles. So now instead of it being displaced more posteriorly, it's displaced more anteriorly. Yeah, it literally is just for Coles or Collies, the bone is displaced posteriorly versus Smith is displaced anteriorly.
So would it spoon upwards? So Coles would make it look like a fork, but then would Coles push it upwards since it's the opposite?
So Coles, however you want to pronounce it, that's the one that's the dinner fork deformity. For Smith, it like nobody really talks about it. Like I would assume that it would have like the opposite effect, but nobody really like talks about that because Coles, is more common. It actually gets the name. So I don't know,
Gotcha.
but I could but you can infer that.
Got you. And the reason for the Smiths one, since it's rare, is because it's weird. Like we inherently want to like land on the pads of our hands, like the palm side. So the way you would get a Smiths is like if I were playing football and then I fell on it the reverse way, right?
That or it's just it's the way that you're falling and the trajectory of the force that you're putting on your wrist. So if you see in this particular patient here, when she fell and she hit, notice how because of anatomical position, the force is going posteriorly. So because her hand is twisted in that direction, technically it's going posteriorly from anatomical position. So that's how you get the displacement of the bone posteriorly. But if say she like fell backwards or fell in an odd way where instead of her force going in this direction, the force was going in that direction, that would get the displacement of the bone that way, which in anatomical position would be anteriorly.
Got you. Thank you.
Sure. What other questions do folks have? So since we have like 5 to 10 minutes, do you guys just want me to talk about the hand since he hasn't really gone over that much? Okay, we'll talk about the hand. All right. So like I said, I will send this PowerPoint to your class rep. Things that I want to endorse. So Dr. Preddy videos always, he's very helpful with this. There's some really good anatomy zone videos. that talk to you about like the distributions of the nerves as well as upper limb arteries. And as always, Gray's Anatomy, Moore, and Netter Atlas are really good books to look at. So, bones. I think I've already talked about the fact that when you have articulation of the wrist bones are articulating with the distal ulna, distal radius, versus the ulna only articulates with, actually, let's back it up. The humerus articulates with the ulna articulates with the radius, and then the radius articulates with the wrist bones, which you can see here in this x-ray. And so when it comes to the wrist bones or carpal bones, you're going to actually need to memorize them. And you're going to want to have a pretty good idea of ossification timing. Ossification is the medical term for like the bones being completely solidified. Our bones start off as cartilage, and then they get like their calcium and their phosphate, and then that's actual ossification. And this happens like after you're born. So you can get quizzed on the relative time like when these bones ossify. So knowing that, you know, capitate is the first one, followed by hamate, and then you get another 2 at around 2 to 3 years, and then another 3 around years 4 to 6, and then the final one, pisiform, is the last one to ossify. So you have 8 carpal bones, and like I said, you're going to have to memorize all of them because you can be tested on which is which. Everybody has their own mnemonic that they use for this. The one that stuck in my head is some lovers try positions that they can't handle. So these all have funny names, so bear with me. But you have scaphoid, lunate, triquetrum, pisiform, trapezium, trapezoid, capitate, and hamate. So you can see how in this picture, starting off, here is, and this is starting off lateral going medial, and then lateral going medial. So here is scaphoid, lunate, triquetrum, and pisiform is actually on the other side. Here's trapezium, trapezoid, capitate, and then hamate. You can see pisiform is actually on top of triquetrum here. And then hamate actually has a hook. You're going to want to know that it has a hook because stuff runs through that hook, which we'll see in a bit. When it comes to counting your digits and your metacarpals, we start at the thumb. So thumb is 1, your index finger is 2, 3, 4, and then 5 is your little finger. When it comes to your phalanges, so you have your proximal, your middle, and then your distal phalanges. And then sesamoid bones are just these little round bones that are just kind of there. They are variable. You can have them in your hands, you can have them in your feet. And technically the largest sesamoid bone in your body is your kneecap. So I will skip this review. You guys can do that on your own later. All right, so we talked about the Colles fracture. When it comes to questions about wrist fractures, oftentimes the patient that they will present to you is an older white female, and that's because of osteoporosis. So osteoporosis will weaken bones, and then a person will fall and then break the wrist. Having said that, my mother, who is not white, and as far as I know doesn't have osteoporosis, she has broken both of her wrists. She fell and broke one wrist when I was in middle school, and then she fell and broke another wrist while I was in college, I believe. So even though the most frequently it'll be like an older frail white woman, it doesn't always have to be. Okay, so when it comes to your carpal bones, the most commonly fractured carpal bone is your scaphoid. However, the most commonly dislocated is your lunate. So you want to memorize those two for those two facts. When it comes to scaphoid, the thing you're worried about is necrosis of the bone itself. So the way that scaphoid gets its blood supply, it's in a backwards fashion. So you can see how this is the radial artery and it's branching off, but then here's a branch that comes and then doubles back to get to the rest of scaphoid. Well, if you break the bone, that means you've cut off the blood supply to most of the bone. So you can actually get necrosis of the bone if you don't catch the break. So most times, even if you do an x-ray, you might not be able to see it. Even if you don't, most people will, like in the ED, they'll put you in like a finger cast just in case, because if you come back in like 1 to 2 weeks, you'll do another x-ray. If they don't put the finger cast on, you'll do an x-ray and they can see that the bone has died. And it's because it didn't have blood supply for that whole time. So here's some good x-rays that are actually showing you like a break of the scaphoid bone. All right, so hamate with its hook. So you can see here's your hook of hamate, and you can also see here is a nerve and blood supply going through the hook of hamate. So you can actually damage your ulnar nerve if you break your hook of hamate. Other thing that's important, so there's a structure called Gunyon's Canal, and deep branches of your ulnar nerve and artery are passing through it. So the canal itself is made out of like tendons and ligaments. But the hook of hamate is like right here. So they're all really close to one another. So if you break your hook of hamate, you can damage your ulnar nerve or your ulnar artery, at least the branches. And then again, pictures showing the breaks themselves. So when it comes to your metacarpals, patients can get what's called a boxer's fracture, which is funny because it's usually from a person who doesn't know how to box. And it's a fracture of the 4th or 5th metacarpal. And it often occurs when an unskilled person punches someone with a closed and abducted fist. So the head of the bone rotates over the distal end of the shaft, producing a flexion deformity. So basically, this is the person who, like, they punch somebody or they punch the wall. Their form was bad and they ended up breaking a bone. Well, that's a boxer's fracture. And so this is what it looks like on x-ray. So a person punched a wall or punched another person improperly, and they ended up breaking their 5th metacarpal here. All right, so it is 3:55. With a little bit of time that we have, I'm going to talk about the carpal tunnel, and then we'll call it. So the carpal tunnel, you can see the structure here. The roof of your carpal tunnel is the flexor retinaculum, and the floor is the actual carpal bones. You have 9 tendons and 1 nerve that passes through it. So this is your carpal tunnel here. So the 1 nerve that passes through is your median nerve. And when you hear carpal tunnel syndrome, that's irritation, compression of your median nerve in your carpal tunnel. Now, the 9 tendons that pass through, you actually do need to know the arrangement of the tendons in the carpal tunnel, because that's another thing that they can test you on. So the easy one, because it's over by itself, is flexor pollicis longus. It's over here next to the median nerve. They both pass through, nice and simple. Where it gets complicated. So your flexor digitorum profundus versus your flexor digitorum superficialis. So your flexor digitorum profundus actually travels flat. So you can see how all 4 nerves just travel flatly, and this one's going to your 2nd digit, your 3rd digit, your 4th digit, your 5th digit, nice and flat. As opposed to your flexor digitorum superficialis, though, those tendons are actually stacked, and they're stacked in the configuration of 3 and 4 on top of 2 and 5. So I think the mnemonic that we use for that one is 34/25. But yeah, so it's flexor digitorum superficialis tendons that have 3 and 4 stacked on top of 2 and 5 versus flexor digitorum profundus tendons. They go flat. Median nerve and flexor pollicis longus tendon, all within your carpal tunnel. And with that, I'm going to stop because we're at like the end of the hour, and I'll stop the recording as well.